Okay, good afternoon. Welcome to Medical Grand Rounds. I'm Bob Wachter, chair of the department. Today is another of our series of what we now call Hollander Rounds, named after Harry Hollander, who is here, esteemed clinician educator, residency program director for a generation. And what Harry was, he's well known for many things, but really probably the greatest was his both personal diagnostic reasoning ability and his ability to teach people how to do sort of the main thing that internists do for a living, which is think through tough cases and make diagnoses. And so it seems appropriate for us to name these Hollander Rounds, and also very appropriate to have one of Harry's disciples be today's speaker. Speaker will be Dan Minter, who is assistant professor of medicine in the Division of Infectious Diseases here at UCSF, as was Harry. Dan's an ID specialist who focuses on complex problems of all sorts of infections, with a particular focus on infections in immunocompromised hosts. He tends on both ID and on the medicine teaching service. He went to college in Seattle at UW, but then became a UCSF lifer and med school, residency, ID fellowship, and now faculty. Not that atypical a story. And he is becoming increasingly known as a superb clinician educator with a particular focus on diagnostic reasoning. And just poetically, he was last year's recipient of the Harry Hollander Award for teaching and diagnostic reasoning. So sort of the perfect speaker for today. And so maybe Dan, come on up and let me give you a mic. Welcome. How you feeling?
Nervous, but happy to see a lot of folks in the audience and folks who've inspired me to go into ID and sort of inspired me along my journey here in medicine at UCSF. So
great. And by the way, sometimes we screw people up, and it may not be an ID case. So just stay on your toes. All right. So the ground rules are that Dan has not heard about this case. Our goal is to learn the thought processes of a master clinician, not necessarily for them to get the case right. My experience, they tend to feel good when they do, but that's really not what we're here for. We're here to see how they think through a tough case. One of the things to show is that you don't need to know everything, although even in the world of AI, it's helpful to know something. It's about the journey, not the outcome. And we will encourage audience participation. We've got rows of ID specialists here in case it turns out to be an ID case, and you're free to phone a friend if you feel like it. Okay. So let us start with the history of present illness. A 70-year-old man with no significant past medical history presented with 1 week of progressive lower extremity weakness and pain. I'll go on, but let me just see. Sometimes I think it's useful to hear just kind of what your blink response is with that chief complaint.
Yeah, sort of weakness, and that's obviously going to clue me into the neurologic system and trying to think. Apologies, I'm still on the pager. Trying to think if it's a peripheral nervous system issue or a central nervous system issue. In my world, just numerically, we see a lot of infections of sort of involving the spinal cord, compressive lesions like spinal epidural abscesses or something to that effect. But want to kind of think along the whole neuroaxis. Is it something in the brain, something in the spinal cord, something affecting the nerves? Or perhaps, maybe non-neurologic weakness. So it's a little bit early, but interested to see where we go from here.
Okay. And the fact that he had pain, does that change your thinking about it at all?
It might move me, if the pain's in the lower extremities, it might move me away from a sort of neurologic cause, unless it's more like painful neuropathy, but perhaps away from like a spinal cord or brain issue.
Okay. And toward what?
Towards, again, perhaps a non-neurologic cause of pain, or, maybe a neuropathic sort of process that's going on.
All right, let's hear some more. So symptoms began shortly after a 24-hour hike. I go on 24-minute hike, so that's a big deal. The following day, he felt fatigue and myalgias in his bilateral anterior thighs, which he attributed to the hike. He then progressed over the course of a week to weakness, difficulty ambulating upstairs, and worsening myalgias, including the entire lower extremity. He had one episode of night sweats and subjective fevers and chills. Then he noticed that his urine was darker and it had acute worsening of his bilateral thigh pain, waking him up from sleep and prompting him to come to the emergency department. On review of systems, already said one episode of night sweats and subjective fever. did not recall an insect or an animal bite, however, was scratched by many plants during his hike in the woods. No upper extremity symptoms, no joint pains, no new rashes, no sick contacts, no falls, dizziness, lightheadedness, or syncope, no diarrhea, nausea, or vomiting, no chest pain, shortness of breath, or palpitations. So you have a fair amount of additional information, including a few positives and a lot of pertinent negatives. What do you think?
Yeah, I think just to kind of add on to what we were talking.
Happy to go back if it's helpful to you.
Yeah, I think if you want to just go back 2 slides, one more. But while you're getting there, I'll just say that, kind of adding on to my peripheral versus central sort of process, a lot of the additional history is now moving us, away from the central nervous system and perhaps, more to the peripheral nervous system and, beyond that even to a myopathic process with this pain in the sort of proximal musculature and, difficulty emulating upstairs. These are, again, not something I see regularly in ID, but buzzwords that I recall from my training here at UCSF, that this is maybe more of a myopathy or something to that effect. Maybe I'll hold on a differential if it ends up being a myositis. We can come back to that later. But maybe other things that could go towards a muscle-related process include the darkening of the urine, the pain in that distribution, and like I said, the pattern of weakness. So I'll be thinking about, as I'm filibustering here, I'll start thinking about infectious-related causes of myositis, thinking about non-infectious related causes of myopathy and inflammatory myositis that, some of our rheumatology colleagues would see.
All right, I'll tell you when you're filibustering. That was not it. Are there infections that if you think it's something going on with the muscle, are there infections that immediately come to mind?
Yeah, it's not a super common thing that we see, but, you can see a variety of infections that will go into the muscle, and it sort of depends on the characterization that would be helped out by imaging, right? If we got a CT scan and then there's this just big intramuscular abscess, that's going to move me more towards bacterial causes, versus if it's sort of just super bright on MRI diffusely, there are viral processes that affect the muscles, notably herpes viruses, and then kind of a little bit more esoteric, some of the parasitic causes like trichinella can affect the muscle as well.
Okay. Let us, and anything on the review systems you wanted to comment on?
I would just say to your direct question of, what are the constitutional symptoms? How does that sort of reframe how I'm thinking about this? This is perhaps more, even beyond just the muscle, a systemic process. It seems like we have cardinal sort of signs of inflammation as well that could push us towards, either an inflammatory process that's not infectious or again, an infectious inflammatory process. So that would, again, just sort of say this isn't a muscle strain. This is going to be something more of an inflammatory process going on.
Okay. Anything else here that's useful, or any of the pertinent negatives sort of helpful as you try to narrow that down?
Yeah, I mean, I'll take with a grain of salt the insect or animal bites. Certainly if that was an arthropod-borne disease, people don't always recognize the insect. I think being outside, sort of exploring the outdoors could, just put them at risk for that. The scratch by plants, I'm not totally sure how that's going to relate. Plant scratches could be a sort of percutaneous inoculation of different pathogens. But, I'll sort of bookmark that and come back to it later if it is relevant. The sick contacts, headaches, yeah, I'm not getting a ton from the rest of the review systems here quite yet.
Okay. And in terms of it being, if it's sort of in your mind competing between an ID cause and a room cause, does the fact that there are no other joints involved or no joint pain or rashes help you at all, or it's still all consistent with either one?
Yeah, I think that I'm still kind of searching for more specificity in the syndrome. If it was, myopathy and pain or myopathy and rash in a particular distribution, is that going to, sort of make me recall different rheumatologic processes like dermatomyositis or something to that effect? If it's myopathy and joint pain, is it going to move into a more systemic rheumatologic disorder? I think myopathy still seems, query myopathy still seems to be the predominant syndrome at this point. And again, I think that we'll get a lot more specificity and kind of an anchoring point once we get a little bit more objective data, is the CK through the roof? Is there, findings on imaging? And then again, sort of what's the pattern? Are there muscles throughout the muscle bed or abscesses throughout the muscle bed or something to that effect?
Okay, great. Yeah.
Myositis and myopathy. You didn't say the word rhabdomyolysis, which I'm thinking you were thinking, because of the dark urine. And I wonder, does that layer, onto your thinking about the etiology of underlying muscle disease from any of these causes?
Yeah, and with rhabdo, I mean, there's
Repeat.
Harry's question was about rhabdo, and if we got to that diagnosis, would that kind of change how we think about it? I think rhabdomyolysis is a great thing that we could say syndromically we're going to have a differential diagnosis for. Is it like exercise-induced, injury to the muscle? Is there some toxic exposure that could also be relevant to that point? Thank you, Harry.
So yeah, and I guess exercise-induced after this 24-hour hike is on the list. That this may be that he's simply burned out his muscles and is leaking muscle enzymes into his bloodstream, and it's in his kidneys. I don't know whether it would cause fever and chills, but not sure. Yeah.
There are some causes of underlying muscle disease that are more or less likely to result in rhabdomyolysis.
Yeah, all right. So we'll get to that. But that is a great point Harry's making, that if this is rhabdo, it probably narrows the differential of both infections and non-infectious causes.
I don't think I realized it was a 24-hour hike. I heard you say that, but man, that's a long time.
It is a long hike, isn't it? Yeah. So maybe we'll find out more about that as we go on. But yeah, it's an unusually long hike. Okay, past medical history, remote history of self-limited histoplasmosis in the 70s, diagnosed radiographically, told he had, quote, nodules on his chest, x-ray, and did not receive treatment. Actually, let's just stop there for a sec. Does histo require treatment or does not require treatment? How do you figure that out?
I think a lot of cases of histo probably go unrecognized, and in a normal immune system, it will come through the lungs and potentially get sort of isolated there. We certainly think of it a lot in the transplant ID sort of line of work, thinking that it can reactivate later on. I think it's not something we see super commonly, so I can't say I have a ton of experience with histo personally, but I think again you would grade it by severity, and if it's severe histo, obviously you're going to be treating. But again, I think that there's probably a larger population under the sort of like the iceberg under the water where we don't really recognize it and we just pick it up later on of somebody has nodules from a histoendemic.
So general rule, I see our ID group, not in their head, general rule, immunocompetent host and incidental finding of histo, just wait it out and it gets better. Yeah, okay.
And again, Brian gave my micro lecture, so anything I get wrong,
yeah.
Aspect.
Brian, yes, that's true. Yeah. Okay, if you couldn't hear, so that it's like Coxie in that way and represents a pretty large percentage of community-acquired pneumonia, doesn't get treated and just hangs out and stabilizes or gets better on its own. So that's all fine. Medications, none, including no supplements, health-related behaviors, drinks about 12 drinks a week, beer, wine, gin, no tobacco use, no other drug or substance use, no family history of cancer or autoimmune disease, social history, former Marine, of course, if he's hiking 24 hours, and retired professor of geology and marine ecology. I don't know if that's the Marine of the armed services or the Marines as in the sea. Visiting, still occasionally lectures, internationally, visiting his two sons in San Francisco. All right, anything you want to say about that before I go on?
Just the, occasionally lecturing internationally. I'm wondering, where has he gone? Has he gone anywhere recently? Already just having this history of histo. Again, it technically is a, sort of present throughout the United States, but there's areas of much higher endemicity. We see it occasionally here in San Francisco, but most often in folks who are coming from other places, a lot of folks coming from Central America. Mm-hmm. But yeah, I'd be interested in the ID side of the social history and exposure history, like where has he gone the last 6 months? Other sort of like specific travel related factors and stuff that could be relevant to this more acute syndrome.
Mm-hmm. Are there pets that you'd want to know about here? And I've just got a dog, so it's front of mind.
It's true. Yeah, my social history is kind of like, where were you born? Where have you lived? Any travel in the last, up to 2 years, potentially, depending on the syndrome. Any sort of health related behaviors, do you smoke? Do you drink? Do you inject drugs? Do you use any other sort of forms of drugs? And then sexual history, what sort of partners are you having? And then animal exposures. I rarely get like particularly strong hits on my animal exposure history, but I love hearing about people's pets, and it's exciting to, see how these folks live and stuff. But yeah, so I'd say, and then sometimes I'll ask, I'm not sure if it's super helpful, but has the pet been sick? Any sort of sick exposures like that.
Okay. But this would be the kind of case where you may not get that history on everybody, but this would be the kind of case where you want to spend extra 5 minutes and learn all that stuff. There may be a clue. Okay, physical exam. And Ella's been helpful in putting the stuff in red that we should pay a lot of attention to. A little hypotensive, O2 sat's fine. And you see here, mouth's okay, telangiectasia on his nose. Neck supple, heart's fine. He's got diffuse crackles in his up to his mid lungs bilaterally. Belly's benign. Extremities, he appears to be tender in the muscles. No edema or erythema, and he's got diminished strength in his hip flexors and the extensors bilaterally. Otherwise, his strength is fine and reflexes are fine. All right. And skin, I'm sorry. 2 to 3 centimeter areas of poorly demarcated macular erythema in his lateral calf. No other rash. Actually, before we go there, anything you want to comment on?
Yeah, I'll say the things that I was expecting versus the things I wasn't expecting. I was expecting the tenderness of the quads and calves, kind of again thinking along a muscular related process. In addition to that, the weakness that we're seeing here on exam. The stuff that I wasn't necessarily thinking about that, could be a sort of inflection point in terms of how we think about this case is the diffuse fine bilateral crackles. Is this, again, a more systemic process that's not going to only affect the muscles, but perhaps extend to other sort of body systems? And then this rash, this poorly demarcated macular erythema in the lateral right calf, I feel like pictures with 1,000 words, it'd be great to see what that looks like, see if it sort of jogs any, associations in my memory and stuff. But I'll say that, again, I'm always looking for, can I combine things syndromically and then get more specificity? So is it muscle plus a pulmonary process, muscle plus cutaneous process. And as we get, more labs, more imaging, stuff like that, we'll sort of go from a relatively broad view of this case and get progressively more specific.
So the pulmonary thing does make you're wondering, is this just a muscle process or a systemic process? That pushes up the possibility it's multi-organ involvement. And the skin, are you thinking is that a portal? Was he bit there or something? Is that kind of what's going through your mind, or what else?
Yeah, I think and again, rashes are, always challenging as an internist, but I think, a way that I've been taught to think about rashes is it like an outside in thing or an inside out sort of thing. So if it's the external world assaulting the skin, you think of it being kind of more localized as opposed to diffusely generalized. So if it's just in that one spot that also seems to have something going on underneath, it could be that, something from the outside world has come in, either percutaneous inoculation, or conversely, maybe there's a primary process going on in the calf that now we're seeing some sort of reflection on the outside of the skin. Okay,
let's see some data. Little anemic, thrombocytopenic, UAUC with large heme, positive esterase, but relatively few reds and a few whites. CK 1200, he's hyponatremic, he's got a little bit of kidney injury, lactates up, sed rate a little up, CRP up. And you see his LFTs there with a little bit of little Billy and transaminitis, and he's got a low albumin for what we thought was a healthy guy. And let's show you a chest film before we get you to comment on the data. So on the chest film, he's got mild bilateral micronodular opacities mostly in the upper lobes, and we're told it could represent infection in the acute setting. Of note, a miliary nodular process could appear, similar for which the differential includes TB and metastases. Some attenuation of the hyla could represent calcified granulomas and nothing else. So happy to go back to any of the data.
If we go back to the lab slide. Again, just processing all this information together, try and see if I can lump different things towards a more coherent sort of series of issues that we can talk about. And thinking again back to the muscle, obviously something's going on in the muscle. You see it on the UA with the hemoglobin, but on the dipstick, but not actually seeing red cells, and then that's confirmed by the CK that's elevated. The AST is probably reflective of that as well. You don't see a ton of abnormalities in the rest of the liver function tests. And then I'll say something that does stand out in this case, and from an ID perspective could kind of shift how we think about it, and that is going to be this sort of combination of anemia and thrombocytopenia, especially in somebody who has had exposure to other places other than San Francisco locally. That's going to sort of start making us think about, gosh, are there tick-borne diseases? Are there other sort of arthropod-borne diseases that could be at play here, just specifically that is a pattern that we'll see sometimes. The rest of the stuff, it's important to note the hyponatremia, but that doesn't really move my needle too much. The AKI doesn't move my needle too much. The lactate, maybe a marker of severity of disease, but again, not specific for me. And then the CRP, ESR, again, we thought this person was inflamed. This is going to be sort of fuel to that fire of thinking that there's an inflammatory process going on. And then, Bob, if we could go to the chest X-ray.
Actually, before we go, so when you say something that floated your boat a little bit was anemia and thrombocytopenia, is that you think there's DIC? Is that you think that there's an autoimmune process hitting both cell lines? What is it that gets triggered there?
Yeah, and I mean, I think just broad, stepping back, just anemia and thrombocytopenia, you're going to ask the question: is there a microangiopathic hemolytic anemia going on, of which could be, sort of mechanical stress on the RBCs or thrombotic microangiopathy? So, it'd be good to get a smear to get a little bit more sense of, outside of the realm of ID, is there, evidence of schistocytes or something going on that would, again, narrow the specificity of our syndrome? From the ID perspective, I'm not sure exactly pathophysiologically why we see that with certain infections. I'd probably have to go do a little bit of research on my own for that. But
Ryan, did you teach that in the class that Dan was supposed to be listening to, or no? Did that not come up? Does he have the pathophysiology, or any of our ID folks, pathophysiology of thrombocytopenia and anemia in certain infections? Is it microangiopathy or setting off an autoimmune response, or what's going on?
I think it depends on which disease you are, consumptive, or you have like rocky spotted fever, clogging up the vessels, or you have that will affect bone marrow production and stuff. There's different diseases.
Yeah.
Okay. But to you, it raises sort of the possibility or the probability of tick-borne illness or
and just an associative sort of, if it's anemia on its own, it doesn't add a terrible amount of specificity, but seeing that sort of pattern of both anemia and thrombocytopenia have associative sort of relations with certain tick-borne things, certain like leptospirosis, some infections that are on our ID boards, but perhaps a little bit less common, in day-to-day clinical practice. But that's already, with this history of being outside, potentially exposed to different sort of insect vectors and stuff, going to be something that I'm going to pin and sort of think about.
And just to Pearl, I think it's still true. This was sort of during my training, was that rhabdo classically causes a lot of heme in the urine, but no red cells, and that's seen in half the cases. The other half don't have that. So it's one of those things where if you see it, it's nice, but it's not pathognomonic of it. And the kidney thing, is your bias that it's just a sick guy, or that it's now another organ system involved?
Yeah,
Yeah.
Oh, okay.
You just okay. Told it a little quick.
Sorry about that. I think that we see AKI on half of the patients we take care of in the hospital. I think the specificity of that particular finding is going to be less, but there are different things. We could consider whether it's more specific as a renal process, or is this just going to be a bystander that this person's sick, otherwise inflamed, and perhaps a little bit dry.
Okay. Chest X-ray you wanted?
Yeah, so I think this is really interesting. And again, I've been sort of like, treading water, looking for specificity. Diffuse micronodular disease on the chest X-ray. It'd be nice to confirm it on a CT just because we'll get a little bit better vision there. But this, I think, is already going to start to raise our alarm about a disseminated systemic process. And with nodules, micronodules, there's different patterns that are much easier to see on a chest CT. But if it's truly randomly distributed versus centrilobular versus perilymphatic, that can give you, again, some clues about how you think about the process. A miliary pattern tends to be randomly distributed, through all parts of the pulmonary lobule, and that's because it's going through the blood, and so it's sort of hematogenious distribution of infection or cancer or some other process that's going on. So again, this is something that we absolutely, from a practical perspective, would want to follow up on a chest CT to get a better idea of exactly what's the pattern and how are we going to think about it. Infections on our end that can cause a miliary pattern, the buzzword's always going to be miliary tuberculosis. That's sort of hematogenious distribution, dissemination of tuberculosis, and it can go anywhere that blood goes. And I remember as an MS3 at the General, I saw TB pericarditis, and I was so jazzed about it. I thought, like, man, this is so cool. I love ID. This, be what I do in the future. So I challenged myself, could TB cause anything else that I was seeing in my MS3 year? And basically, if you Google it, you'll find it, because TB goes wherever the blood goes. But yeah, so if you do have miliary tuberculosis, that's something that could have a similar pattern on your chest x-ray. Endemic fungal infections like cocci-histoblasto can do something similar. I think it's interesting this person had, obviously a history of residence or travel to a histo-endemic area given their prior history of histoplasmosis. And we can see some signs of that with this like calcified granuloma near the mediastinum. So that would be a sign of old histoplasma as well. But again, I'd be interested exactly where this person go in recent memory, getting a little bit more specificity on the chest CT. I'd say on the non-ID sort of side of things, certainly different rheumatologic diseases can have, nodular patterns on the in the lungs. Malignancy can be disseminated in a similar miliary pattern. I think there will, talking to our chest radiologist, probably be a little bit of clues when we do get a chest CT on that.
Okay. And so you've already said you want a chest CT. Any other imaging that you want? I guess you mentioned earlier you want better imaging of what's going on in the muscles.
Yeah, either a CT or an MRI of the thighs, I think will be helpful. Getting a chest CT will be great. I don't recall that we had, basic blood cultures. So, but Harry talks about the blocking and tackling, the things that we want is our first set of stuff. And then, specifically, where did this person go? I'd probably think about, more specific ID related labs based on that travel history. And then, like I said, the blood smear, I think, given the hematologic findings, will be important.
Great. Okay. So we start getting some more specific results. Blood cultures, no growth at 12 hours, HIV negative, flu negative, COVID negative. You see the HAV, HCV, HBV, core antibody positive on HBV, EBV, IgG positive, IgM negative. ANCA's negative, ANA less than 80, myositis panel, I don't know what that is, but sounds like something you should do now, is pending. All right, and you wanted a chest CT, which has numerous punctate randomly distributed micronodules through the lungs, which may be hematologic spread of disease, including TB or fungus. Additional areas of ground glass may be related to early interstitial disease. Scattered calcified lymph nodes, likely related to remote granulomatous disease, including the histo, partially imaged indeterminate density hepatic lesions in the right hepatic lobe. Consider additional imaging. You also wanted a study of his extremities. And so MRI, diffuse feathery edema, I assume that has some meaning in the world of MRIs of muscles. Signal and mild enhancement within the bilateral thighs, right great and left calves. Symmetrical, most pronounced within the right vastus lateralis. Non-specific, but can be seen in myositis. Okay. No MR evidence of myonecrosis. Deep interfascial edema may be reactive to the myositis. A deep space infection like neck fash cannot be excluded. No evidence of osteo. T2 hyperintense lesion 2 centimeters in the right proximal calf near the neurovascular bundle, favored to represent a peripheral nerve sheath tumor. All right.
Excellent. And then can we go back to chest CT? So our initial suspicions of a potentially miliary or hematogenously distributed process are now a little bit more confirmed. We can feel a little bit more solid in that footing based on the chest CT. And the things that I'll point out is the random distribution. Again, that is going to narrow us in towards things that are hematogenously distributed like TB or like histo or potentially cocci. So we can think about what are we going to discard? What are we going to focus on? I feel like this is sufficiently abnormal and sufficiently specific that this is probably going to be one of the big anchor points or pivot points for our case going forward. I would be interested in what's this person's risk of TB acquisition. We mentioned they traveled internationally. My TB sort of exposure history is like, have you ever been told that you were near somebody with TB, or have you known somebody who's been diagnosed with tuberculosis? Have you ever had a positive positive PPD or positive quantiferon in the past? And then kind of, where have you lived in your life? Again, getting back to that exposure history. Some of the other, softer risk factors, we talk about incarceration, we talk about marginal housing, things like that. And then often, even healthcare workers, are at risk for TB. The histoplasma, in somebody with a history of prior histoplasma that they've been able to sort of contain, it's possible that they could reactivate with, disseminated histoplasma. I'll keep an eye out. It's an easy test to send. the histoplasma urine antigen, and it'll be interesting if that is positive or negative, because if it is as disseminated as it appears to be, I would expect the urine antigen and or the serum antigens to be positive. So I'll keep an eye out for a test like that. The other stuff, the mediastinal calcified stuff, again, fits with his prior diagnosis of histoplasma remotely. And then I'm interested about the hepatic lesions in the context of something that we're already sort of anticipating might be a hematogenously disseminated process. Blood goes to the liver. Could that be like an abscess or some sort of focal lesion from whatever process is affecting the lungs, or at least we're seeing a little bit more easily in the lungs? And then if we could go to the MRI. So we talked a lot about, hey, I think there's some muscle process in OS going on. Now we've kind of moved a little bit more progressively specific towards myositis. This would be a scenario, again, because I don't see myopathies or myositis all that frequently in when I'm on medicine or when I'm on ID. So I would go chat with the MSK radiologist and say, like, hey, you look at these things all day long every day. Like, what does this sort of ring in terms of bells for you in terms of potential diagnoses? It seems like we're not seeing obvious abscesses like I was saying before, and that would be a more specific finding if there was an evidence of like pyomyositis that, again, could be more bacterial as opposed to an atypical process. It seems a little bit more diffuse. I'm not sure what to make of the feathery edema, like you said, Bob, but potentially more diffuse, potentially related to whatever's going on in the blood. And then the interfascial edema, the radiologists, they rely on us to provide the context for these reads. What are you putting in the reason for the scan? I'm less, you always want to think about neck fash whenever there's something going on in an extremity or potentially angry cellulitis looking part of your skin. But, for me, this doesn't quite seem like neck fash given the progression and the rest of the stuff that's going on. So, I would chat with them, get a little bit more of their thoughts on that. But, that's not something that I'm necessarily jumping for right now. Although it's always, it's a hard diagnosis to make and it's a high consequence diagnosis. The T2 hyperintense lesion, is this where the skin thing is? That would be a question that I have, because again, they lack the context when they're sort of just blindly reading these scans. If it is a nerve sheath tumor, then, that's probably unrelated to whatever's going on. But if it is, maybe it's not a nerve sheath tumor and it's related to that cutaneous thing that we're seeing, this could be an area that, might have some diagnostic utility if we were to go after a biopsy or something to that effect.
Great. So let me just highlight that, and I'm proud of you that you're doing a lot of old school things. Like the key things at this point are not some fancy genomic something or other.
That would have been
actually getting a history. I know you're going to want that eventually, but it's getting a better history and going and talking to the radiologist. Those are probably the two most important things you could do at this stage. So I completely agree with that. So the patient was asked more details about the hike. Looks lovely if that's where he went. Just prior to travel to San Francisco, he completed a 24-hour hiking excursion through the rainforest in Micronesia. Who hasn't? He lived in Micronesia for the last 5 years. Prior to Micronesia, lived in Uganda, Thailand, and the Ukraine. Traveled to over 100 countries throughout the world. Routine water exposure in both marine environments and fresh water. Drinks water collected from rainwater, but filtered. Routinely exposed to feral dogs. Yours is not, right, Dan? Yours is, okay. Occasionally comes in contact with mice and rats, no farm animal exposures. Describes a diet that consists of local fruits and vegetables and fish. No raw pork or unpasteurized dairy exposure. All right. What do you make of all that?
No, nothing, raising any.
Nothing going on, nothing to see here.
Yeah, this feels like one of the, ID.
Hold it a little closer. Yeah,
this feels like one of the ID board exam questions, right. Yeah, where to start? Micronesia, obviously this raises a lot of potential infections that we don't see here in San Francisco and urban area all that frequently. It sounds like he has strong risk factors for stuff from, different parts of the world. And when I think about, travel related infections or infections related to different parts of the world, I think like what's there, what are endemic infections to that area? What are infections related to the activities that person has done in that area? What are infections just related to the act of travel in itself? And then what are infections related to, certain activities like sex that people have in, sort of different patterns when they're traveling than when they're at home. I'd say, thinking what's in Micronesia, my amateur geography, would say that this is probably going to be related to, more tropical related infections like leptospirosis, which could honestly not fit terribly with the clinical presentation. You know, calf pain is a prominent feature of leptospirosis. You can get diffuse alveolar hemorrhage or pulmonary involvement, and it can affect the liver. It can affect different parts of your body.
Where do you get it from?
You can get it from, it's basically, it sets up like shop in the kidneys of different animals, and then they excrete it in their urine. There was like a study, I think, out of Baltimore where they like surveyed the rats of Baltimore, and like most
actually spoke to them, or what did they do?
No, I remember reading this, and I remember Harry talking about it when we did a CPS club when I was a resident. But you know, it's like the vast majority of rats in Baltimore have lepto, so it's something you can find all over the place. But it's also in
case any of you were thinking going to Hopkins, just remember that. Okay.
You know, so that's something that could fit, and also fit with our pattern of like the thrombocytopenia and anemia. Other interesting things, you know, from the rickettsiosis bucket. For that part of the world, I'd have to double check, but I think there's probably scrub typhus. So Orientia tsutsugamushi, it's a rickettsial species that is in East Asia. I remember this because on my ID boards, it was like somebody who was hiking through Vietnam and then got bit by a spider, got bit by a rat, and then also got a the chigger related tsutsugamushi, Orientia tsutsugamushi. So anyway, that could also fit with a sort of anemia, thrombocytopenia, febrile syndrome, multi-system oriented thing. A lot of stuff previously, depending on how remote the travel was to Uganda, Thailand, Ukraine, it's like, are these infections that could reactivate, TB being the kind of most common one that we would consider. The water exposure, again, that's going to be a risk factor for leptospirosis, like I'd mentioned, but, anything else that could be, like fecal oral contamination and is a mode of acquisition for an infection. Occasionally comes into contacts with mice and rats. So there's rat bite fever, put that out there. The farm animal exposure, people often they can get farm animal related things without having close exposure to that. So anyway, there's a lot of different potential etiologies here. I would say probably rising higher is going to be something like lepto. I would probably send a rickettsial panel at this point. And then again, look for any spot that I might want to biopsy and get a little bit more specificity on the muscle stuff. But I think the lepto test is easy. I didn't mention histo right here, but given the micronodules, I'd send testing for histo, probably send AFB blood cultures given the diffuse micronodular disease for disseminated tuberculosis. See if they're, it's easy to get sputum for tuberculosis as well. So I might try that as well. I'd probably start there. Realistically, this patient probably also got a metagenomic next generation sequencing, so we can see if that comes back.
Okay, so I'm gonna speed it up a little bit till we get to the end. I want to be sure we have time for discussion. Got a bunch of fluid, concern for rhabdo, developed an increasing oxygen requirement, worsening pain in his legs, got Lasix, didn't improve, got Vanco and Piptazo. Hospital day 2, developed acute worsening and develops respiratory failure, emesis, worsening respiratory failure, PCO2 of 27, and oxygenation marginal on 60 liters. Lactates 5, intubated, goes to the unit. Rival unit, progressive shock, 3 pressors, stress dose steroids. All right, just take a second on that. I assume you're going to try to support him. Is there anything else you would be doing in the acute phase?
Yeah, again, I think, now we're transitioning from like diagnostic reasoning also to the sort of field of management reasoning of like what sort of therapeutics are we going to implement in the interim as we're trying to figure out what's going on with this patient. So obviously, terrible multi-system related thing going on. We have to think of our common things being common, bacterial infections, kind of rising to the list of what's causing septic shock for most of our patients. And then also layer on like all these weird things that could be happening, like leptospirosis, like, Orientia tsutsugamushi. And then sort of think about, how broad are we going to go and specific antibiotics are we going to include? So I think broad spectrum stuff like a vancomycin, vancomycin makes sense and would cover, leptospirosis. We often think of it as a doxy responsive or doxy deficient state, but it's kind of like syphilis. It's like very, very exquisitely susceptible to beta lactams. So I do that. I'd probably also add doxy just in case there were like Orientia tsutsugamushi or some other, terrible rickettsial thing that we wouldn't be covering. I think that would be probably where I would start for this patient, and then just have really close eyes on them and collaborate with members of the ICU team, other sort of teams that are involved in this.
Just because he's really crashing, you covering for TB, you covering for histo, or you're going to hold tight on that?
That's a good question. I think I probably wouldn't quite yet. but that would be a question that we'd probably discuss on rounds of would you add ambisome. Covering for TB, it's challenging because it's a multi-drug regimen and it ends up being relatively messy.
Mm-hmm.
But I would, here we're in a great spot in San Francisco that we have close access to, Janice Louie and the TB clinic that are world experts and can provide consultations on this stuff. So I'd probably run it by them, but at this point, probably not unless I got more of a story that they had TB exposure.
All right, quick poll of our ID people. Cover for fungal infection at this point? None of you, really?
For somebody who's big respiratory failure from resuscitation for yeah, and I personally would have just
sounds like nobody's covering for fungus. I assume nobody's covering for TB either at this point. No. Okay. There you go.
I don't think it would be wrong, and I think reasonable minds could differ.
Yeah. All right. But none of them did here. All right. I'm not going to read off all the labs. You see, I'm looking for black type. Basically, everything is wrong. He's got now a big leukocytosis, cytopenias in the other lines, elevated ferritin. He's got his LDH is up, haptoglobin's up. His kidneys are failing. All of his LFTs are up. His CK is now up to 10,000. So I think fair to say getting sick. All right, now the ID people have kicked into full gear. So again, I'm not going to read all of this. This is basically the I guess there's the ID ordering box where you check everything. Any comments you want to make about this? Is this the appropriate response? Just check for everything, and then if you see things that are red, anything that you want to comment on?
I think that this should, yeah. I mean, I'm not surprised by a lot of these. I think the malaria is a good call, depending on how recent the travel was. That's numerically one of the more common endemic infections related to travel in different places. See a lot of stuff that's pending. The histo stuff, the ID, the different antibodies are more relevant for chronic forms of the disease. As opposed to disseminated disease, I'd be more interested in an antigen. They're kind of similar for the Coxy. I don't think this is going to be Coxy, but we probably would have sent it. The rickettsial panel, it's interesting. It's probably not going to come back for a while. Probably a week or two is my guess. And I guess I'm surprised that they don't have the Carius there. The leptospira antibody, again, probably not going to come back for a while. There is an antigen that we don't have available here, I think, that you can send. I double check that. I might be wrong on that. Mm-hmm. I think you can send PCR directly for lepto. But a lot of the issue with lepto is it's, there's the sort of leptospiremic phase and then an immune-related phase that actually causes kind of more of the, terrible end organ damage with something called Wheel syndrome. It's like the syndrome of, AKI, interstitial nephritis and, LFT abnormalities and potentially alveolar hemorrhage.
Do you say that's an immune phenomenon? Does that mean that the lepto test may be negative at that stage? Or?
I mean, the antibody probably would be positive, but again, it's going to come back in a timeline that's not going to be super helpful, which is why, again, potentially the PCR. Oh, we do have the Carius pending. Excellent. Yeah, this is UCSF. Perfect. Yeah, so I think, this sounds like a pretty good start. And again, I might add the antigens for the endemic fungal stuff.
Okay. So we talked about that. And so a little bit more on his hospital course. He's intubated, he's on triple pressors, he's spiking fevers. Despite his antibiotics, he's on renal replacement therapy. He's now got jaundice, worsening thrombocytopenia and anemia, antibiotics changed to ceftriaxone and doxy. Ampho now added at that stage, worsening skin lesion on inner biopsy. Biopsy shows hemorrhage consistent with coagulopathy. Okay. And he has a BAL. The results of the BAL are shown here. Bacterial negative, fungal cultures pending, KOH negative, respiratory negative, MTB PCR negative, a bunch of stuff other pending. And he's got a non-friable mucosa, basically it. Okay, continued hospital course. Amazingly, after he was a sick guy, extubated, shock resolves, off pressor, stress dose steroid stop, trialed on intermittent hemodialysis, and by day 7 transferred out of the ICU. That is quite something. All right, so before we get to a diagnosis, which we might assume one of those tests came back positive for something, what do you think this is likely to be?
As a betting person, I'm going to say lepto seems to be the most consistent, again, with this sort of multi-organ, organ failure syndrome that does affect the liver, does affect the kidneys, does affect the lungs, and has these sort of hematologic parameters that are perhaps more consistent with lepto. That's probably going to be my number one. It could be any number of things still at this point. One thing I didn't mention earlier, but again, with travel to that area, potentially disseminated process, strongylosis hyperinfection syndrome can sometimes produce something similar with, the sort of uncontrolled replication of the strongylosis parasite going multiple places in your body. But, I think that I'm going to come
usually in immunocompromised people, right? Isn't it?
Typically, yeah. There's some risk factors like HCLV infection that create increased risk for that we might not have picked up here, but I think it's less likely to be that. The rickettsial disease that I mentioned, or Tsutsugamushi, possible, it could fit, but I think that's more, I think they'd have more cutaneous manifestations. So I'm going to say lepto and be humble and acknowledge it could be different. Okay. But I'm glad that they're doing better. So
great. That was fabulous. Come up while Ella's coming up to tell us what this was and tell us about it. Harry, any comments?
Just a question for Dan. Was Legionella on the list?
I didn't put it on my list. I'm not sure if it was up.
Okay, I don't. Well, I'm just thinking about a pulmonary process, relatively acute pulmonary process with rhabdomyolysis, and the other thing I'm wondering in the context of lepto is, could some of the worsening have been, if this were lepto, precipitated by the initiation of antibiotics with a Herxheimer reaction? And we tend to think about that with syphilis, but it happens with other spirochetal diseases.
Okay. And Harry, you've done dozens of these in ID cases. Would you have said lepto as your diagnosis?
I think so.
All right. Ella Cornell, who's our chief resident, who prepared the case. Thank you, Ella. Will tell us what it was. There we go.
Yeah, thank you so much. Thank you, Dan, for that awesome reasoning. This is a case of lepto, a really interesting case with a very quick hospital course, but with a lot of turns. And ultimately, the diagnosis was made clinically and then confirmed with metagenomic sequencing. And so the file diagnosis here is what Dan had mentioned, which is Wales disease, or icteric or fulminant leptospirosis. I'm speaking to a lot of amazing ID specialists here, but I'm just going to do a quick rundown for all of our medicine colleagues on what lepto is. It is caused by this Leptospira species, which is a gram-negative spirochete. It's actually the most common zoonotic infection in the world. An estimated 1 million cases occur globally each year, and actually result in about 60,000 deaths each year. It's mainly transmitted through contact with urine of infected animals, as we mentioned, rodents, livestock. And some risk factors that I wanted to highlight here in particular are either occupational exposure or flooding. And this can be seen and has been seen in the US, including in the Bay Area, with instances of flooding. And as you know, flooding increases throughout the world with global warming. This is something we might actually be seeing more frequently. It is also endemic in tropical and subtropical regions, as was mentioned here, and I mentioned the flood. The clinical presentation. So the incubation period can range from anywhere from about 2 to 30 days, so quite a long range, but symptoms usually begin about 5 to 14 days after exposure. There's the anecteric disease, or the more like self-limited disease that we see, which has an acute phase of fevers, chills, myalgia, and this conjunctival suffusion, which I have never seen, but this like hyperemia of the conjunctiva. And then it can just self-resolve and kind of you go about your day, or it can come back in 2 to 4 weeks later with multi-system damage related to the immune response, as Dan had mentioned here. In that case, you see renal failure or liver damage and some aseptic meningitis as well. And then the alternative is this Wales disease, which is a much more fulminant and immediate severe multi-system organ syndrome. So just kind of running through the timeline of what you will see, you'll see this initial kind of myalgias, headache, the conjunctival suffusion, and then progression to jaundice with an increase in bilirubin, renal failure, rhabdo, and then that thrombocytopenia and anemia that Dan had flagged early on. And then pulmonary complications can lead to pulmonary hemorrhage and ARDS. And then, of course, shock and DIC can also be present. And about 5 to 10% of symptomatic leptospirosis cases can present as this Wales disease, and it does have an associated mortality of about 5 to 15%. The diagnosis, really clinical suspicion, that's really going to be guiding, which is why this is such a great case for CPS. And then you can get blood and urine PCR and the serum IgG and IgM. Of course, that the serum antibodies will come a little bit later. And if you're already having this immune phenomenon, your urine PCR and blood PCR might not be positive. The treatment for early stage or mild would be doxycycline, and then severe cases, we think about IV penicillin or ceftriaxone. And then doxycycline you can use as prophylaxis for high-risk exposures. There is the reaction, as Harry had mentioned, which I can never pronounce, that once you initiate antibiotics, you can have like a worsening of all your symptoms similar to syphilis with antibiotic treatment, which could have happened in this case. So that's our clinical summary. I'll leave it to Bob to kind of have reflections, but thank you so much, Dan, and thank you for the case.
Thank you. So why don't you take a second and reflect on the case and sort of lessons that you learned from doing it?
Yeah, I think, hearing travel histories like this, I'm like, gosh, my life is very boring compared to a lot of these people. So, no, it's a great case, and thanks for putting it together, Ella, and it was really fun to discuss. I think it's a good one to flex general medicine muscles, kind of like Harry was putting out, like the rhabdomyolysis and kind of starting broad and then, progressively getting a little bit more specific. And once you have that syndrome, sort of layering on the exposure history. So that's kind of how I think about it with ID is, try and get my problem representation. What, do I think this person is immunologically at risk for? And then what's their syndrome? And once I have their syndrome, if there's something atypical, go back to basics, back to the exposure history. And this is the fun part about being an ID consultant is you get to ask all these fun questions about what people do in their free time. So I think it was a really, really interesting case, tough case, and really appreciate being allowed up here to do this. So.
Yeah, thanks. It was terrific. Any role, I don't know if you came across this, any role for steroids or something, given that when they're crashing, it's largely an immune phenomenon rather than an infection?
From my reading, it sounds like that is something that people have suggested and probably had been shown to have mortality benefits.
Okay. Can you tell us a little bit about this metagenomic thing? Like we're sending it a lot, when do you send it? And are we going to reach a point at some point and then who knows when in the future where that's just everybody comes in and we send that and it tests for everything? And is that where we're going?
Yeah, and I'll just preface this by saying there's better people in our division to give that talk. Natasha Spottiswood's done a lot of work in it. Monica Funk's done a lot of work in it, and then obviously the laboratory colleagues like Charles Chu and so on. But I'd say we are using it very frequently. It's kind of an unbiased test. You saw that list of tests that we had to come up and on and say like, hey, should we send Bartonella? Should we send Brucella? You have the thought to send that test. More specific tests versus metagenomic next generation sequencing, like the my simpleton's way of thinking about it is it sequences any nucleic acid or DNA that you can find in the blood, suppresses human DNA, and then tries to map fragments that it does sequence against a library of known infections. So you can go into it, say like, I don't know what's going on, but try and see if there is any nucleic acid that you can pick up. It's not like a end-all test, and there's a lot of issues that we run into it when it's sent and we get the result back and like, gosh, this doesn't make any sense with syndrome. I'd say a lot of the time with like bacterial stuff, if it's not present on a blood culture, and it's like staph epi or Enterococcus faecalis or something, it pops up, and I don't have that on a blood culture, probably pay attention to it, but don't necessarily change practice or change my antibiotic management. If it's an obligate pathogen like Bartonella, like Mucor, or something like that we're seeing in the right host, then it can be kind of a really, really important test. And on the immunocompromised ID service, transplant ID, we see a lot of cases where like, I don't know how you would have made this diagnosis, otherwise, for like pulmonary Mucor, you get your bronch and you don't really find anything there, but it pops up on
how long does it take to come back?
Well, there's been changes recently. I think they moved it in-house over the past couple of weeks, and I think that's going to decrease the turnaround time. But previously when we were sending it out, the biggest bottleneck was like actually getting it sent and collected correctly. But after that, it'd be like 2 days. So.
Right. We have a few minutes for questions. Anybody have any questions or comments?
Was the cutaneous manifestation something you see with lepto? And it's like why, like the progression of the calf rash or the inner thigh and the peripheral nerve sheath ended up just being.
So the question was that peripheral nerve sheath thing just red herring or real, or and then was the rash? Do you think the rash was related to the syndrome in some way?
Yeah, certainly a subset of patients with lepto will get a rash. I'm not sure if that particular rash was related to lepto. It'd be interesting if it disappears after the disease resolves. But yeah, I can't remember exactly what percentage, but it's like, a chunk of them will have a rash. The more common things that you see on like board exams are like the conjunctival suffusion, like Ella mentioned. I can't say that I've seen a ton of lepto cases, probably like 3 or something during my training, doing rotations other places. But I think if it goes away, it's probably related. But
Ella, do you know whether the rash turned out to
be a red herring?
Red herring.
Yeah, it was an injury probably related to the height, and then became progressively more bloody in settings.
And did the peripheral nerve thing get worked up, or don't know?
Nope, just a pin for the future. But
all right, so red herring for probably both the rash and the peripheral nerve finding. Any other questions, Brian? Hang on, I'll give you the mic.
I still find the miliary pattern on the CT scan quite confusing because, as you said very clearly, like we have a limited differential diagnosis. It's hematogenic spread. I don't have that, lepto on my differential for miliary pattern. Was this an incorrect read? Was that truly the pattern that we saw there? I made me confused.
Did it make you think of something? I mean, assuming it's the right read, think it's the histo that's that or something else, or
if he had miliary histo a long time ago, does he still have small areas of peeled nodule? And usually you think the miliary stuff would go away.
Yeah, the only way I was reconciling it is like, the alveolar hemorrhage being a prominent manifestation of, lepto, but like were those actually just kind of little micro hemorrhages that we were seeing? I don't know. It doesn't fit particularly well either. And I was hoping on the BAL that it would be like, serial, aliquots with blood and stuff.
A quick comment on the rheumatology side.
Yes, please.
Since that came up early in the case, there were 2 key clues that made like a primary rheumatic disease very unlikely in his initial presentation. And the first was pain predominance, and the second was the acuity of onset. So in the inflammatory myositis bucket of diseases, you have antisynthetase syndromes, you have dermatomyositis, you have immune-mediated necrotizing myositis and inclusion body myositis. And all of those have their own specific patterns and presentations, but the only one that tends to present with pain is immune-mediated necrotizing myositis, either due to statin exposure or a positive SRP antibody. And that also tends to be more subacute to chronic, and all of the other ones, again, subacute to chronic presentation. If someone has acute onset pain predominant symptoms, rhabdomyolysis is at the top of the differential, either due to an infectious or traumatic cause, and all of the immune-mediated primary.
So none of them cause sort of an acute rhabdo presentation. Even immune-mediated won't attack the muscle that way and that quickly and cause that much pain. That's great. Thank you. Thank you. Any other comments or questions? Yeah.
He was crashing in the ICU. We talked about
for
TB. Can TB cause like acute multi-organ failure like that? And when would you pull the trigger on covering empirically?
It's uncommon, but there are cases of like TB sepsis. The case I had a case that was crashing and burning in the ICU, but it was like an immune compromised patient. You can't get miliary TB without immune compromise, but it's less common, and you can't get TB sepsis, but it's a subset of TB cases.
Your general paradigm, is it pretty much never empiric TB treatment?
No, I mean, there's this whole world of empiric TB treatment, especially you kind of like, it's a Bayesian sort of thing, because you're testing will take some time to organize and result. So, they have this sort of WHO classification of like, what's your suspicion as a TB suspect, TB5 high, TB5 low, and stuff like that. So, it's all about thresholds of like, okay, obviously you've met my threshold to test for TB. Have you met my threshold to treat empirically? But again, TB sepsis, it's described not all that common. I've only seen like one case, and I think it, interested my colleagues if they've seen a ton of TB sepsis cases, but it's not like a very frequent thing. So probabilistically, I don't think I would have met my threshold to empirically treat, just because like, they are already neutropenic, there's all these drugs going on. It's, kind of a drug interaction mess and challenging to do.
Yeah, I guess I was surprised that nobody went to the fungal treatment with this guy crashing and every organ failing. So
yeah, and we always think, is it bacteria, bacteria, virus, fungal, mycobacteria, stuff like that. And on that differential, it just doesn't necessarily fit with my illness script for how a lot of fungal disease presents. Obviously you can get, HLH related to histo, HLH related to other endemic fungal infections, but this overwhelming like crashing and burning, that doesn't necessarily fit with how I think of like, oh, what's the most common ID related problem? And again, none of these are without consequence or downsides. And, ambisome 5 mg per kg daily, you're going to trash already bad kidneys and somebody who's experiencing organ failure. So I think it's a risk benefit analysis.
All right, we need to quit. Thank you so much, Dan. That was terrific. Thank you, Elle. That was great. Thanks.